Hi everyone, I'm Mike Abadi and welcome to Vermont Senate Spotlight. We are very pleased to welcome Claire Ayer here today. She's taken time out of her busy schedule. She is a Democrat, Addison County, and the chair of the Health and Welfare Committee in the Senate. So you've got a lot on your plate. We just had crossover last week. Friday was the deadline to move bills from the Senate to the House or vice versa.
That's correct. If they need an appropriations or if there's a tax, they get an extra week because they stop in finance or appropriations.
Oh, okay.
But we have to get it there by crossover.
Okay, so this is the week where you're receiving stuff from the House and sending to the Senate.
That's correct.
Senate sending to the House.
That's correct.
Okay, so now we've kind of shortened the list of potential bills that may become law. Is that basically
I think so. If they haven't passed either the House or the Senate, it's probably not going to happen.
Right, and it's the second half of the biennium, so
That's
nothing's going to jump over. All right, so I would actually like to start by talking about some latest headlines having to do with the Shumlin administration saying they won't have the financing plan for universal health care ready. And in the House, I believe Cynthia Browning, who is a Democrat, has made a public records request to say, we could use whatever information you have so we can do our work. And you, it seems, as the chair of the Senate Health Committee, may have a stake in that little back and forth. I don't know, how does all that look to you right now?
Well, Representative Browning is one of 180 people, and she's she's really good with numbers and so on. Has always been concerned about the financing of Green Mountain Care, as is everybody from one perspective or another. I was surprised when I heard the announcement that we weren't going to get a financing plan this spring, or the bones of a financing plan, and asked some questions about it, and they're not ready.
Right.
They just don't feel that they're ready to pull it off, and I think they're a little sensitive now to the idea of opening things up before they're quite ready to go. Like,
Sure.
for example, the exchange, the healthcare exchange, we had a federal deadline of October 1st, and they had to open it, even though we switched contractors and got started with CGI late, and we certainly weren't ready to go live on much of anything, but we
Right.
had to.
Right.
And it's been a humiliating experience, I think, for the administration and to a lesser extent the legislature, but a frightening experience, I think, for people who are worried they're not going to have health care. They think they've got it, then they think they don't have it, and then they have a card. I mean,
Sure.
So there's been a lot of back and forth, and it's all fine for people who aren't sick, but when you're sick, you need that kind of support, and there have been a lot of people who've been very frightened by it. So because of that, the administration, I think, is very sensitive to the idea of stepping out there with a plan before they're ready for it. And we know that no matter what, it'll be taxes, right? Instead of paying $15,000 or $18,000 out of your pocket, you're going to pay more taxes, probably income tax, probably payroll tax.
Okay.
I don't know what there may be some other things that go with it, but we know that as soon as we put it out there, people are going to shoot holes in it. I mean, it's just, that's how we do it. No matter what idea you put out there, it's going to be subject to a lot of criticism and a lot of review, which it should be.
Right.
But I think they're just sensitive. They don't want to go out there until they can answer all the questions or think they can answer all the questions.
Sure.
Then 180 people still have to say it's a pretty good idea, plus the people who vote for us.
Right. So we expect when the administration rolls out a financing plan, it'll be a one thing, or will there be a menu offered to the legislature? Is that part clear?
It is not to me. Now remember, in the House, the same committee does healthcare insurance, healthcare financing, and healthcare policy, and a separate committee does mental health and public health.
Oh, that's really divvied up.
In the Senate, I do mental health, public health, human services, and healthcare,
right.
But the financing and insurance packages actually go to finance. So I'm involved in that, or our committee is involved in that. We look at how progressive taxes might be. Are we getting the right kind of balance to make it sustainable, to get the right people paying the right amount, that sort of thing, and what they're paying for, what kind of options they have.
Okay.
So I forgot the question.
No, I think you answered.
Oh, okay.
Actually, speaking of responding to questions, the governor was asked, could you name some other payment plans beyond a payroll tax?
Yeah.
And he said, did he say?
He said bubblegum and lollipops,
Not
I
unicorns
think.
and rainbows, but bubblegum.
Yeah.
So is that flip answer actually mean it really is a payroll tax? There really is not much else going on except kind of fantasy land stuff.
Well, what we've looked at, I mean, right now we have a very small tax that we pay on healthcare premiums every time there's a claim. It's a few cents. There are a lot of little things that you don't see every day where we pay for healthcare and our property taxes and that kind of thing. So it's possible there'll be more options than income tax and payroll tax. And there'll be things that aren't so obvious. The last time we looked at what a financing plan might look like last year, we got basically a menu. If you raise the tax on lollipops, you'll get $5. If you raise the tax on bubblegum, you'll get $10. And that's the kind of list you can get from our financial people any day of the week. So it really wasn't a plan. And we'll be looking for a lot more than that, because remember, it has to be progressive in that people with more money should pay more, who can afford it, and people with, I happen to believe that if you have almost no money, you should still pay $1 a week. I think everybody should pay, but it should be based on your ability to pay. So we have to decide, where's the cap? You know, on Social Security, you pay full Social Security on your payroll up to a certain point, and then you don't pay again. So are we going to do something like that? And are there going to be lower limits? There are people who think that at a certain level, people are so poor that to even take $1 or $5 a month from them is
sales tax hit them hard, for instance, right?
Yeah, those kinds of things. So we want to make sure it's progressive, and we want to make sure it's sustainable. That means that it'll be good over time. If you tax something and that causes the demand for that to go down or the income from that to decrease, it's not sustainable.
Right.
So we have to look at pretty steady sources that we can be sure of over time.
Sure. This problem really brings out just how many different types of situations people are in presently. If you're like a small business, or if you're a freelancer in the workforce, or if you work for, you know, a larger institution with good benefits, or if you're unemployed. So somehow all of those are going to have to get folded in. People on Medicaid are going to get folded into the exchange, or that's awaiting federal waivers, or how is that going to?
Medicaid's already been folded into the exchange,
Right.
to the extent that it goes by income, and if it's below a certain point, you're put into Medicaid. But the idea of the exchange and all this health information technology that was supposed to be so great and will be great if we ever get it right is, say I don't have a job and I don't make enough money to pay insurance, but I finally get a job. I can call that in, and they can just move me to the next level. It's automatic. Or if it's a seasonal job and the ski lift's closed and I'm unemployed again, I can move back and forth.
Okay. Now,
And people with Medicare, people like me, we still have our Medicare. We will be separate, but anyone with Medicare knows that you need at least a second insurance plan to pay for doctor's visits and medication and that sort of thing. So the idea there is that Green Mountain Care would be the wraparound, the second insurance policy.
Medicare would continue to stand alone, but you could get a supplemental.
Medicare only pays for hospitalization and a few things like that, so it wouldn't pay for what healthy people need. A few medications, a couple doctor's visits, some preventative stuff. It doesn't cover that.
Okay. Now help us understand the difference between the exchanges that the state had to build for ACA and what we eventually want to have or will end up with.
Well, the Affordable Care Act, Obamacare, the health insurance exchanges are mandatory federal creatures, and the idea was, we had a federal attempt to get health care for everybody when Hillary Clinton, when Bill Clinton was in office, and that was a big flop. So I think Obama's best best shot at it was to make sure that everybody had health insurance. And this is the way to do it. Would make it easy to go online and shop, just like Orbitz or any of those kinds of programs. You compare prices, and then you pick the one you want. We look at your income, and we think, gee, it's okay, you can pay full boat, or gee, it's a little shaky, so we'll take off a few $100s a month. That's the fantasy. It hasn't worked quite as well as we'd hoped. Small businesses have gone back to the insurance companies. So that was one issue about the exchange. And what was the second part of the question?
Well, just what will the universal health care that Vermont wants to build, I mean, independently of the exchanges or out of the exchanges? There's going to, something more in Vermont is going to grow out of that.
Right.
And
we will ask for a waiver. We'll say, please don't make us stay in the exchange anymore. And we do that all the time with various federal programs. But we'd like the money you were going to give us for Medicaid, for the supplemental for the assistance you got paying your premiums, and those kinds of things. It's called global commitment funds. We'd like to keep all the federal money, just give that to us, and let us manage those funds, and we'll cover everybody, and we'll meet all your standards.
Okay.
Which is something we do now for other programs.
Right, right. So the exchange is almost a temporary measure, and we kind of know that. Or will that be a skeleton of
Well, building
what
the
is coming?
exchange, one of our dreams, the Agency of Human Services, which is the biggest budget in government, has the finest technology of the 1960s or something. It's just awful. So we wanted to design an exchange that it looks at your income and discovers if you're eligible for help with your health care. But we would also be able to use the same system to see if you're eligible for food stamps or WIC or any other kind of state program. We wanted to be able, it was mostly going to be an eligibility thing, and we were hoping to use the eligibility portion of that for other parts of state programs.
Okay.
But we got mad at CGI and dumped them, so that's all on hold, and we will rebid that second piece of it. And they say, what I've heard is that if you think the exchange was complicated, wait till you see this, it's called eligibility software, that's supposed to talk to people in corrections, on parole, food stamps, preschool, all those things that we help with.
A huge database with a lot of tentacles going in different directions.
Yeah.
Huh.
So we had hoped to use that for eligibility, but we want to move to a place where it's not a matter of if you're covered. You are covered for, we'll look at that gold plan and we'll base our numbers on that. So we don't have to check every time you come in the office or have a test to see if it's covered. But we still want to keep the data. Do you know about the data that we keep? We'll know that you're a 20-year-old guy with diabetes. That'll be as the result of an insurance claim. We'll know what kind of medicine you get, what your blood sugars are, because that's all covered by insurance. It's called the VCures database. And when you can get information like that, we can look at all the 20-year-old diabetics, see which medicines work the best, to see if you're overweight, which interventions help you get. So we use that as a way to improve quality of care. We still need to keep that.
That's more for diagnostic and treatment than payment. That's not actually the...
Right, but they're connected because that's how you know what it is. Dr. Smith is going to write, I gave, Michael had this blood test and I gave him this medicine and this was his diagnosis. So somehow we need to keep that information so we can always improve care.
Okay. Now, there's that whole HIPAA privacy stuff. Would that be attached to someone's name, or it would be a floating sort of person that...
Thank you for asking that. It's called de-aggregated or de-identified data.
Okay.
Yeah.
Got it.
That would be against the law, and we would be in huge trouble.
So
it's personal information.
It's unattached. Gotcha. Maybe helpful to look back a little on how we got here, the history of planning to build and building a universal health care system for the state. Really, it was Dr. Chow from Harvard offered up, designed 3 plans for the state. One was kind of a straight payer government paying directly to
Right.
health
Yeah.
providers. The second one was very much like the exchange system, but with a public option.
Insurance, pretty much.
Right.
Yeah.
And then the third, which is what the legislature and the administration went for, is a hybrid model, a public-private,
Yeah.
single-payer model. Do you have a sense of, like, I guess, how private it is? It's Blue Cross Blue Shield is an administrator, and then we have
Well-
this whole, the tech people are private. So do you have a sense how hybrid this hybrid is? I guess.
Well, you have to realize, because if we were a whole country doing this, we could do single payer. But because we've got 4 borders at least, and tourists and travelers and so on, we will not be a single payer. We'll have people from Detroit and
Right.
people from Florida, Canada, New
Sure.
York, so on. So we'll always have to be able to process claims in some way. In terms of who's going to run the program, it might be Blue Cross Blue Shield, but we will bid that out. We
Okay,
will
so
ask.
that's actually not secured. Okay.
No, that is not secured, and in fact, there are a lot of legislators would like to get that nailed down so they can start getting up to speed. You can't just tell somebody, in 6 months you're going to do health care for the whole state.
Right. Right.
So we'll ask the administration to design that bid specifications and award it in a way that gives whoever it is the opportunity to get up to speed. But one of the recommendations Dr. Schau made was that process should be bid out every few years to make sure we stay lean and mean, we don't get too complacent, that we use the latest technology, and maybe the market will work in our favor for healthcare.
Huh. Okay. So that may not necessarily be in whoever wins that bid's back pocket forever.
That's
there would
correct.
There would be a
Which
performance.
is, that's
piece.
sort of a stimulus to do well, to
Right.
do best, and to be able to prove it.
Right.
Yeah.
Now, there's a legislative oversight piece to what's going on now. Is there a specific panel or committee in the legislature that looks at this as it's being built? And I don't know if checks
Looks
customers.
at the universal health care
Yeah.
as it's being built. Well, we have the committees of jurisdiction, like Senate Healthcare and Senate Finance in the Senate. In the summer, we have the healthcare oversight. But one of the things that we will request as we look at how we're going to run the program, it's called the operational plan, as we look at that is to add in an oversight piece. There ought to be other sets of eyes, not the administration, not the contractor, but other people who are looking at this who can understand, if we're doing all right. And
Okay.
what we
So
need.
there was a summer sort of oversight.
Well, there always is for healthcare issues that come up when we're not in session. It wasn't specifically for the exchange.
Got it. Okay, that helps a lot.
Yeah.
All right, so questions are slowly getting answered.
Yeah.
And I think probably this is such a large level of change that creates some worry and panic.
Real anxiety.
So when things aren't going perfectly, people can imagine, am I going to get...
Well, the way I picture it, there are a lot of things we're doing. A big piece of Dr. Schau's proposal was that you need to save money. You spend more of your, almost 20% of your total economy on healthcare. You spend more per person than any other country in the world, any other country, and you don't get the best healthcare. You're like number 20 in this list of developed nations. If you could save some money by how you do care, instead of, it's sort of piecework that we pay for every time you go to the doctor. She gets paid or he gets paid, that kind of thing. If you paid to keep people healthy and you're rewarded healthcare providers for that kind of work, they don't get it now, and you paid for them to be more collaborative, and there are just lots of ways we can do that. All of these reforms, delivery, payment reforms, the ACOs that the hospitals are doing now, where they're going to try to deliver better care for less money and keep part of the profits. But there are other pieces to keep an eye on and make sure everybody gets good care. Hospital budgets, looking at pharmacy benefits. We need to do all of those things.
There's a lot of moving parts.
Yeah, and that's what my committee will be focusing on. How are we doing? Does our trajectory look like we're going to get there?
Right.
But we have to I can't remember where I was going with that. We have to be able to do those things before we can afford it. There are a lot of moving pieces. So there's the financing, there's the structure and the oversight, the administration, and then there's this cost savings that's related to improving quality too.
Whew.
It's really interesting, and but it takes a while.
Yeah.
Yeah.
Maybe it'd be helpful to get out of the big picture and just look at crossover. On last Friday, it was the last day to get your bills moved.
Right.
And so you were incredibly busy last week, I imagine, and it probably spills into this week with what's the Health and Welfare Committee looking at for bills that have come from the House? Are there things were ready for you to?
Well, we sent them some interesting ones that
Okay.
they'll
You wanna start
timely
there?
treatment or involuntary medication that'll take up time in judiciary and in health and welfare. It's called the Human Services Committee because they do mental health. That's the big one. We'll also be sending over the skeleton of a bill that gives us. You have to have a bill. You can't just make something up 2 days before the end of session.
Sure.
That'll say we want the administration to do the bids on the bid contracts. We want to make sure we look at all the cost savings that we're doing those. We need a consensus forecast. That means we have to agree that we're saving that kind of money. And it lists 4 or 5 things that we want to happen before we can get this final number.
Okay.
We'll do that. That'll be out of out of finance this week.
Got it.
That's the big one.
So that went from health to finance, and then it can go to the House.
It's a collaborative effort. We'll be going into finance and saying these are the pieces that we need to have to make sure we have some structure. If we have to pass a bill that says this will be the law, this has to be done, we have to have a bill. So that'll be that. But it'll be considered a work in progress. The House is ready for it. They're working on it. It's just there's a lot of collaboration. A lot of things change through the year.
How does it's the involuntary medication for psychiatric patients.
Right.
How would that change present law if passed?
Well, presently, this bill is actually designed to be with outliers. We had people come in and tell us, and it's happened over 4 years, and it's mostly their children, went into the emergency room in an acute psychotic state, and it was 100 days, 3 months before they got treatment. And between every time you're in a hospital, you should be, all of the things that happen to you should be therapeutic if you're in a psychotic break. But there are people who are in a space where they're afraid, they think everybody's trying to kill them or poison them. All they know is they're locked up and they can't get out.
Right.
So for that patient who is also dangerous, because supposing it's me, I'm going to fight you every time you come in and try to touch me or talk to me. I don't want you. I just want to get out. I'm refusing treatment. I'm refusing to engage with you. And I'm dangerous because I want to hit you or kick you. And people have been severely injured. So for people who are dangerous to themselves or others, and for people, and young men in particular, are troubled by schizophrenia, and they have the same. They'll come into the hospital, resist medication because they feel fine. They think they are who they are, and this is the real me, and everybody else is not so good. That we've seen before in the last couple of years, and we know what medicine works for them. Those 2 groups of people, their lawyers or the hospital lawyers or the Department of Mental Health lawyers could ask, could we get a hearing early and medicate these people? We know that for this young man, he comes in and out of the system, he goes off his medication. We'd like to be able to treat him and get him to a place where they either consent or not consent, but it's informed consent to treatment. And the other person is a person who's dangerous to staff or to themselves. Can we medicate this person to get them to a space where they can either consent or not consent to treatment? The other thing that happens is we actually added another check-in from judiciary. There's no doctor or nurse in this situation can treat somebody without a judge looking at the evidence. And they don't just say, oh, you want this, and check it off.
Right.
They talk to us about actually weighing the issues. And when you're looking at somebody's rights to not be medicated, the scale is really different. You have to have a lot of evidence to show that that's a good thing. Out of 450 people who came into the system involuntarily, we ended up, most of them are settled, they get better, they develop a relationship, with their caregivers, and only 45 of them ended up being involuntarily medicated. That's
Okay.
a lot if you're one of those people. But
Right. So the bill would tighten up the hearings,
For two,
speed up the
for
hearing process?
two very small groups of patients, that might be, we're not sure how many that is, 10 or so, the doctors could ask the judge to take a look early.
Okay.
For everybody
Is
else,
now there like a lag period built in? Or?
oh, there can be months for these people because all they have to do is appeal, and there are unlimited appeals, so it goes on and on and on. The thing that we added, I don't know if you remember, there was the case of an Essex Junction woman who was in the hospital for 5.5 weeks, and at 5.5 weeks she finally had a hearing, and they said, go home, you don't need to be here. But under the new bill, within 5 days or 7 days, a judge will look at the paperwork, the reasons on paper that they sent that person there and say, you can go home. This is not sufficient. So we give the opportunity for some people to go home much earlier, for a very small group that we know to be treated a little earlier, and everything else is the same.
Okay. So that is...
We won't have unlimited continuances. That'll be harder to get that.
I see, okay.
Yeah.
So the appeals process couldn't spin
It
and
will,
spin.
Sometimes there are circumstances that change, and both the lawyers for the Department of Health and lawyers for the patient will say, neither of us are ready. The kinds of continuances that we thought were possibly being overused were mostly on the part of the lawyer saying, wait, there's more information, wait, I can get more information, wait, I'm not ready. There are times when everybody agrees that there's not enough evidence to convince a judge, and the judges, it's just a waste of time for judges to do that.
So it did pass the Senate?
It did.
And it was a close call, or did it okay?
No, I think it was 4-26, but it was a really tough issue for most of us. I don't know anybody for whom it was an easy question.
Right.
And it started in Judiciary, and they passed it out with a 5-0 vote. We passed it out with a 3-2 vote out of our committee.
Okay. So Judiciary was a little more unanimous, completely unanimous.
They were, but they look, we try to look at it from a quality and access to care point of view, and it's really hard to tease those things apart completely.
Right.
And they were looking more at process.
Yeah.
So it was clear to see they added another layer of judicial oversight, and it was clear to see that this group of patients that were medicated was a very clearly defined group. Judges had a hard time because we didn't do that before for this one
really
group, and everybody else stays in the same system.
Got it. It gets quite complicated when it seems when medicine and the law meet. There's so many issues that come together. But I'm actually getting the word, can you believe we're done?
No.
Yeah.
Really?
So thanks for clarifying a whole bunch of stuff.
No pun
big
intended.
picture, and also right in the moment with crossover. So thanks a lot, Claire.
My pleasure.
It's a
Pleasure.
good clarity
talk to
now.
you. Yes.
Yep. Bye-bye.